Hi, this is Yaz Dabul, live from SCAI 2019, and I'm pleased to be joined by Dr. Andrew Klein. Dr. Klein, thank you so much for joining us.
Oh, thank you.
And today we're going to talk a little bit about PE response teams. PERTs have become a new trend in medicine, and they've been expanding, and things have been looking pretty good for PE response teams nationwide. Tell us a little bit more about what is PERT and what are some of the challenges, or let's start with maybe the unmet need. Why did we even need PERT in the first place, and then some of the challenges.
Great, so that's a great idea. I think a great topic to launch into. I think the critical aspect about understanding about PE and pulmonary response team is that it's a pulmonary embolism response team. So it is a team approach. I think as in medicine, we're definitely moving towards this as we understand the need to have multidisciplinary key players basically involved in the treatment of a condition that is one of the leading causes of death. I think we all know patients that have had massive PEs. We have many, many famous people that have dropped dead of PEs or been hindered by PEs. And I think the key thing is that if you look at the number of patients that are being affected, it's just below that of stroke. And so we really are seeing a large number of patients that need care. They need consistent and quality-based care. And so I think the idea behind a pulmonary embolism response team, it's not just about doing interventions, it's about bringing key stakeholders at your hospital together to be able to figure out what's the best way to manage all patients with pulmonary embolism, be it the low risk, to the intermediate risk, to the high risk. And the critical thing about pulmonary embolism response teams is that it's in response to a disparity of care, and even at individual hospitals, how a PE is treated on the orthopedic floor may be different than the medicine floor, may be different than the ICU, and that leads to disparity of care, which leads to decreased quality of care. And I think what we're seeing here is a movement together, bringing key stakeholders, both from hematology and oncology, pulmonary critical care, your interventionalists, which could be anywhere from an interventional radiologist, vascular surgeon, interventional cardiologist, and then kind of coming back around and making certain that we're having all the medical care of the patient solidified so that you can really get the best outcome we can.
Yeah, what is the role of the interventional cardiologist on the team? Knowing that there is an interventional radiologist, maybe pulmonologist, how does a cardiologist basically stand within this team?
So I think it depends from hospital to hospital, and one of the nice things about pulmonary embolism is that it really depends upon who has a passion in this, who really wants to jump on board. Doing the interventions can be done by any one of those three major players. I think as a cardiologist, you have an interest hopefully into right ventricular mechanics, right ventricular support, which often impairs upon the left ventricle. So cardiologists are perfectly positioned to do this. It does not mean that they do it better. It doesn't mean that they do it differently. It's just the idea that at each hospital, it actually may be a combination of various specialties doing it. In fact, at our hospital, we have 4 vascular surgeons and 3 interventional cardiologists that work together as the interventional component, working closely with our pulmonary critical care team and ICU team. And so we work, along with hematology, we work very, very closely as a network. Who's on for the interventional side? It doesn't really matter at the end of the day.
Now, somebody can argue that with a team that big, there could be too many cooks in the kitchen. How do you mitigate this kind of basically so many stakeholders, everybody's input? At which level you decide we're going to do this versus something else?
Yeah, so I think that's a challenge. You bring up the point is that there's not a lot of data in this space. There's not a lot of consensus data, and you have a number of different societal input from, be it from the interventional radiology side, from the American College of Chest Physicians, be it from, you get all these different ways about, do you treat the patient, do you not treat the patient with an intervention? How do you do it? Well, we do it as a team. It's who's on for the day, and whoever's on the team for the day, you're not getting 30 people's opinion, you're getting 4 people's opinion. I think that's important. That being said, for patients that are getting escalating, the patients that are sicker and perhaps massive PEs, or that are more involving our shock team, maybe going on ECMO, obviously you're interfacing with that team as well and making certain that we're all kind of moving in the right direction, with the caveat that there are multiple ways to do this, and right now we don't have data to say absolutely one way is the absolute one way to do this, and that's why we need the data and the RCTs.
And so far, PE response teams, how has the feedback been nationwide from the hospitals that do have PE response teams, and what are some of the future steps basically to improving these response teams?
So I think the first step is forming one. and the recognition that there's disparate care at your hospital. So the first big issue is addressing this major public health concern and understanding that PEs, many of them could be prevented with good DVT prophylaxis. Getting that good composite team together at each individual hospital is the next step. So if you're not in a PE response team right now, but you want to bring one to your hospital, a lot of resources out there, the PER Consortium to tap into, which is a large national consortium of PE response teams. I think that's probably our greatest resource right now. Where our challenges are and our future steps are really putting some data behind things.
Yeah.
I think we have some great data out there for catheter-directed therapy, but really, is it catheter-directed therapy? Should we be doing half-dose lytics, or maybe we should just do medical therapy? And I think you're going to see, depending upon where you go in the United States and in the world, very different techniques, very different ways of doing it. Again, all based in some data. We just need some really, honestly, comparative effective data to really show us what's the best way to go. So as we move forward, our goal, I think, over the next 5 years is to really push this towards a evidence-based strategy so we can get the best outcomes for all our patients with PE.
Are there any ongoing randomized control trials basically regarding PE response teams?
So there's versus not PE response teams. We don't have an RCT saying, your hospital X has a PERT, your hospital B does not have a PERT.
Yeah.
I think we're going to see that with our and there's some it's not a randomized, but it's going to be retrospective, looking at that from the National In-Hospital Database. I think right now the idea is we are still very much in the infant state of we have to crawl before we can walk, before we can run. And I think the idea behind getting all our data together in one composite under the PERTS consortium and trying to figure out, okay, what's the best way to treat patients? And I think the hard part about PE is that there's low-risk patients that we all agree about, and then there's massive patients that we can talk about nuances, but we agree are very sick. There's a huge population in between, and that each patient is a little bit different. It's not like a non-ST segment elevation MI where, okay, you're positive troponin, you're going to get a left heart catheterization. This is, okay, where are you on the gradation of how sick you are, how big is your PE, who's going to go on and get CTEPH or other long-term issues, or who's going to continuously still be short of breath 6 months later. And I think that's why we get into this, is really we don't want patients to be limited by their one event that may impair the rest of their life.
And so far, the consortium registry, can you share with us some of the the figures that we have so far? How many patients have been enrolled?
So it's very infantile. We just saw the PER consortium data is still enrolling. There were 40 founding members. Now we're up to over 100 PERT teams worldwide enrolling data. That data literally is going in, as we know, into the database. So we don't have a time, or I don't have privilege to know how many patients are in there yet, but I think we're going to see some really good data out of there in the next two years probably, to really get through and clean that data up and try to say, okay, at your hospital you do this and you get these outcomes, at my hospital we do Y and we get these outcomes. Let's figure out what's the best strategy. Maybe it's a combination, maybe it's your way, my way, whatever it may be. Again, in the setting of a very challenging patient population, because there's such a wide disparity between how they present.
Yeah, Dr. Klein, thank you so much for sharing that information.
Pleasure.
And thank you all for joining us live from SCAI 2019.